I'm going to go ahead and say just welcome to everybody. And thank you so much to Ross and Eduardo for having me. I'm so thrilled to be here with you guys today. I've been listening to these HCP rounds, these hemodynamics and perfusion rounds. They're fascinating. They're such great topics. And I'm so thrilled to be here to talk today about a topic that I think all of us really enjoy talking about. Because it's something that, you think is quite niche. And then as soon as you start looking for it, you realize that's actually very common. And it's such a fun ultrasound diagnosis to make. So I'm really pleased to be here, and thank you everyone for joining us on the webinar today.
Thanks for coming, Katie. Yeah, it's great, and I think the last time we talked together was in Vancouver, actually at the TEE course. So it's been a little bit, but thanks for hopping on.
Yeah, thanks for having me.
All right. Well, before we hop into the full discussion, firstly, again, I already gave a bit of a plug here for the course here in Toronto, but if you want to sign up, you can also sign up with the QR code. It would be great to have some of you there and to hang out with Eduardo and I. And then we also want to thank our sponsor for HCP rounds. Flowsonics has been sponsoring the whole season of HCP rounds, and they are actually the producers of the first wireless wearable ultrasound patch that can measure carotid blood flow and jugular blood flow, and in doing so allow personalized and really phenotyped resuscitation for sick patients. And I've said this before, we weren't really looking for a sponsor for HCP rounds, but when we had this discussion with them, it made total sense because their mission really is to make precision fluid management easy and accessible to clinicians, not just with advanced ultrasound training. And that really fits with kind of our mission here, which is to spread knowledge surrounding hemodynamics and perfusion. So thanks again to Flowsonics Medical for sponsoring this rounds. And they'll be at the course in Toronto as well. So if you want to connect with them and check out their technology and the flow patch there, that would be another great opportunity.
Thank you again to Flowsonics, and we'll delve right into our subject, which is dynamic left ventricular outflow tract obstruction. And I think this is really a high yield use of your ultrasound machine and your ultrasound skills. It's really the disease where you would miss it out completely if you didn't look at the images. I mean, when we assess an acutely ill patient, we usually think of different physiologies. So you're either your distributed shock, your hypovolemic shock, your obstructive or cardiogenic shocks. And there are ways to get around it without ultrasound. I mean, you could measure pressures, you can estimate cardiac output, you can use your clinical judgment to really think of the physiology underlying your patient's shock. I don't think there's really a shortcut or an easy way to realize that your patient has acute obstruction of the LVOT, and it's really causing the patient deterioration without imaging. And this is why, this is such an important subject for us POCUS lovers. And I'm glad and thrilled and really excited to have one of the experts, world experts in pulmonary ultrasound, especially for critically ill patients. And thank you for being here, Katie. And maybe you can kick it off with this subject, which we all love.
Yeah, of course. So again, thank you guys so much for having me. I love these rounds that you're doing, and I'm so thrilled to be here. So I'm going to start by taking us through the topic relatively briefly, kind of going over some basics, and then we'll get into kind of some more nuanced discussion. Each of us will share our thoughts on sort of some key questions or some tricky questions we brainstormed beforehand. So the definition of a dynamic LVOT obstruction is obstruction to the LVOT, or we'll talk about mid-cavitary gradient, so an intraventricular obstruction by structural abnormalities that is provoked or altered by changes in loading conditions. So something that's not there all the time, but in the right physiologic milieu becomes apparent. And I always show this first, right? Because the classic example of this is always HOCM, hypertrophic obstructive cardiomyopathy. And this is where most people learn about this concept and where you become familiar with this. And we think about this occurring in this context in the SAM there. And so most of you are very familiar with this. The physiology, to remind everybody, right, is that in cases such as HOCM, when you have that hypertrophy, you get a very, very small left ventricular outflow tract, right? You get very high flows through a very narrow area. And that flow, those really high flows generate a bit of a suction effect if we're talking about left ventricular outflow tract obstructions, such that the anterior leaflet of the mitral valve actually opposes the septum in mid-systole. That's SAM, systolic anterior motion of the mitral valve, causing an obstruction to outflow. And when you measure this with Doppler, which we'll talk a bit more about later, you get this classic dagger-shaped flow, which is that abrupt cessation in flow in systole due to the obstruction from that anterior leaflet of the mitral valve. Now, That exists in HOCM, and we're all familiar with that, but you probably don't see that many HOCM patients come across your practice. However, this is something that as soon as you start looking for it outside of the HOCM population, you realize that this occurs a lot more frequent than we usually assume. So I usually think of this in terms of two kind of main buckets. So we see this when we usually have a mixture of some sort of predisposing cardiac pathology, though not always. And I have to say that I've seen this in people with structurally completely normal hearts, and then the right loading conditions. So the predisposing cardiac pathology is typically left ventricular hypertrophy or a sigmoid septum. Those would be the most common, but there's a few other theirs that I've kind of thrown on. And then the precipitating conditions, this is what we're going to talk about in more detail, but this is where I really see this. So hypovolemia or diastolic dysfunction, low filling pressures that we'll get into more. A hypercontractile state, so whether that's extrinsic or intrinsic inotropy. And then low systemic vascular resistance or vasodilation. There's a few others there that I've thrown on, but those are the three big ones where it should really flag that this is possible. I have just one paper in here just to kind of show you how common this is. So this is a few years old now, I guess almost 10 years old. But it was a study where they screened for this and everyone admitted to an ICU with septic shock. Now, I have to say that the cutoffs they used for significance are lower than what I would typically consider clinically significant. But just basically to show you that this exists on a spectrum, and probably a lot more people than we recognize have a degree of this, especially when they're critically ill in the ICU. So they found this in 22% of their patients to some degree. So this is out there. If you look for this, you will find this. So when should you look for this? We'll talk a bit more about this in the questions, but these are the few things that always kind of make my antennas kind of stand up. So anyone who is getting really sick, especially anyone who's getting sick with the addition of inotropy or the up titration of vasopressors, shock that really seems out of keeping with a degree of hypovolemia, so a bleeding patient that just seems so shocky, that's really out of keeping with how much blood they're losing, for example. No one is doing this, but this is the exam answer for the HOCM patient, right? If you're listening to their murmur when they're going from standing to squatting, but please don't make your critically ill patients do this. But really, and we'll come back to this later, everyone who is sick, who is in shock, especially the people who are getting worse, I think deserves a POCUS with an attempt at measuring cardiac output. And we'll show you shortly that if you are looking for cardiac output and stroke volume in these people, this is how you pick this up. So we'll talk a little bit about the actual ultrasound techniques for doing this. This kind of presumes an understanding of spectral Doppler, so the differences between pulse wave Doppler and continuous wave Doppler, and knowing how to calculate cardiac output and stroke volume using LVOT VTIs. We'll talk a bit about like whether you can get away without these. The short answer is kind of not. So I'd encourage you to go back. I think that an LVOT VTI is a really fundamental technique for people doing POCUS and looking after kind of critically unwell patients. So you may screen people. So the first thing that you probably see when you'll throw your 2D probe on is a hyperdynamic heart, not to be confused with a tachycardic heart, but a hyperdynamic heart where the EF is greater than 70%, a small LV cavity. And then with color Doppler, you'll see very high flows, so aliased flow in the left ventricular outflow tract and an apical 5-chamber view, like we can see there on the right. So this is the first thing to show you that like, maybe something's going on. This isn't enough though, you got to keep going. This is really your key image. So when you go to, and this is a crappy 2D image, but it gets the point across. So when you go to measure their stroke volume, which you would do in an apical 5-chamber view using pulse wave Doppler right in the left ventricular outflow tract, instead of getting a traceable, nice kind of triangular shaped modal velocity, even when your baseline is as high as you can go and your scale is as high as you can make it with pulse wave Doppler, you're going to get this aliased uninterpretable flow. So very, very high velocities, just that waterfall of flow as opposed to something you can nicely trace. So this should be your clue that something is going wrong here, that there's very high flows across this outflow tract. The next step to actually quantify this is to do that exact same measurement, but this time with continuous wave Doppler instead of pulse wave Doppler. So you'll know that continuous wave Doppler allows us to measure much higher velocities. It's not limited by a Nyquist limit or a PRF. So we can bump our scale way, way up and we can now measure these really high velocities. And now you'll get something that you can actually trace. You can trace a VTI here. And the number that we typically pay attention to in this case is the maximal pressure gradient. So you can see here our maximal pressure gradient is about 80. In the HOCM literature, they cite a gradient of about 30 as being significant, or 50 with exercise. So 80 is very, very high. So this is going to be causing hemodynamic problems. So here you've diagnosed the pathology. For bonus, and Ross will talk a bit more about this later, you can actually go back and identify the level of obstruction, right, as to whether this is right in the outflow tract or whether this is more a mid-cavitary gradient occurring back in the left ventricle. And what you're going to do here is use your pulse wave Doppler, start in the left ventricular outflow tract, and then slowly step that back with repeated measures until your tracing goes from uninterpretable alias flow to something traceable. And there you've identified the location of your obstruction. You can also go back with 2D and try to identify the SAM, so the systolic anterior motion of the mitral valve, which will occur obviously if there's an LVOT obstruction, not if you have a mid-cavitary gradient, but if you have an LVOT obstruction, you should see SAM. Now, I point this out as something to go back and do after rather than something that you should catch immediately, because I find this really hard to see usually. These people are tachycardic, their 2D views are often not great. It's really hard to see. It's something where I have to pause it and scroll through frame by frame to try to pay attention to this. So to me, this is something I go back and do after, kind of as a nice like bonus to myself to prove that this is there. You can also look for MR here, because this usually will occur as you have that anterior leaf of the mitral valve being sucked up, you get consequent MR. You can also use M mode as a nice trick to identify this SAM in a parasternal long axis view. So as you would measure an EPSS using M mode, in addition to your typical E waves and A waves that you would see, you'll get a third peak in systole where it shouldn't be, where the mitral valve should be closed. You'll get that third SAM peak. And then management, which we're going to get into more in our questions because there's some nuances here, but is basically reversing precipitating factors. So addressing hypovolemia, blood if they're bleeding, right, or fluids, addressing excessive inotropy and chronotropy, and then low SVR. So we'll talk a bit more about this in our questions. So I think that's all I have for our introduction to the topic. And this may be something that's quite new to you, or this may be something that you're familiar with, but I guarantee that as you start looking for this, this will come up more and more. So I think Ross was maybe going to lead us off into some questions here.
Yeah, absolutely. Do you mind just showing the first question there? So
Absolutely.
we're talking about dynamic LVOT obstruction, intracavitary gradients. We've given some physiologic conditions that actually precipitate this, but in clinical practice, when do we actually see LVOT obstruction and intracavitary gradients? Maybe Eduardo, kind of in your practice as a nephrologist, caring for a lot of patients with cirrhosis and having a research interest in that, what sort of patients are you seeing this in?
Yeah, well, let's go back and remember what's the actual underlying cause of this obstruction. And this is an empty, very empty LV cavity, right? And so for your LV to be full, it needs to have high preload and it needs to have time to fill up. So there shouldn't be a lot of tachycardia. And then it should have something to resist against it emptying. That's called afterload. And so whenever you have the combination or any of these issues really present in a severe manner, such as severe low afterload or severe low preload, or a very highly tachycardic patient with very high inotropism, your LV might just empty out. And so where do we see this? Well, of course, patients with liver cirrhosis and hepatorenal syndrome, which might come, or infected patients with cirrhosis, which might come with very low vascular resistance, will usually present with some gradients, especially since the treatment we use in hypotensive patients with cirrhosis is an inotropic and chronotropic drug, which is norepinephrine. And then this is where really switching to a vasopressor that does not have these properties will not increase heart rate and will not increase inotropism, such as terlipressin or vasopressin. And skipping your norepinephrine will really change the course of this patient. Now, curiously enough, we also see this in end-stage kidney disease patients with long-time hemodialysis or renal replacement therapy. For some reason, which we don't actually know why, they develop vasoplegia. And so this might, they would just start presented with syncope and come to the ER because of that, and then we'll see an interventricular gradient or an LV obstruction gradient. And of course, when we're talking about low vascular resistance, I mean, the king, and where you will see this the most, I think, in my opinion, will be your crashing septic patient. And, this is really important. Just go back into some of the slides that Katie presented. Just don't go back, but you remember them. When you're assessing cardiac output in this patient and you look at a really crappy imaging, a really crappy Doppler imaging of the LVOT, and I've seen this happen many times, some people would just trace it and say, oh, this is high cardiac output, so this is really a distributed physiology. You cannot interpret LVOT VTI if the tracing is not nice and crisp with a nice modal velocity and a spectral window and a nice thin spectrum. And so for your crashing septic patients, I think this is a very high yield exam. But certainly we cannot examine all our crashing septic patients with ultrasound, or maybe you can. In my practice, there's just too many of them. So, knowing that this condition exists, what would be your approach, Katie, to saying, well, this patient might be obstructed, I might need to scan them? Are you scanning them all, or are you looking for clues, maybe peripheral perfusion, pulse pressure, tachycardia? What clues are you looking for in order to go and say, I cannot miss LVOT obstruction in this patient?
Yeah, I think all of those things that you bring up are excellent, right, Eduardo? So the patient who was looking exceptionally crappy and worse than you think they should. So the patient who was modeled, reduced urine output, poor cap refill, maybe a really narrow pulse pressure. But to me, I maybe you can't scan every septic patient, I'll buy that, but I think everyone that is like deteriorating shock absolutely deserves a scan, right? Because that to me is the biggest clue, because it won't always be this. Sometimes it'll be surprised they have a pericardial effusion or they have a ruptured mitral valve or other things. So to me, anyone who's deteriorating deserves a scan. And in particular for this condition, anyone who's deteriorating as their norepinephrine escalates, or in particular, if anyone decides to add like some epi or some milrinone and then they really crash, that's a huge flag for, maybe this is dynamic LVOT obstruction. Anything you want to add there, Ross?
Yeah, no, brilliant point. There's three populations I think of in particular in the ICU where we see this a lot. So septic patients, absolutely. The other one is patients with bleeding, particularly those with low afterload from cirrhosis. So I find that these patients might have kind of a mild GI bleed, or maybe they have a bit of a post liver biopsy bleed, and you restore hemostasis through some sort of procedure, or the patient's bleeding stops, you've given them some blood, but then they deteriorate again and you think, oh gosh, they must be bleeding again. So you start treating them as bleeding and they respond because they're fluid responsive. But then they are persistently fluid responsive, even though the hemoglobin actually isn't dropping maybe when you recheck it. That is definitely a huge clue for me. So sepsis, these kind of bleeding patients, and then post-cardiac surgical patients, if they've had mitral valve repairs or if they have other procedures that change the diameter of the LV or the physiology there. Another one would be aortic valve replacements, because some of these patients, if the aortic valve replacement was for aortic stenosis, when the afterload is reduced from the new valve where there's no kind of stenosis anymore, the LV, which is typically hypertrophied or often hypertrophied, then kind of creates this like suicide LV it's referred to. Really, that's just severe LVOT obstruction, typically from intracavitary gradient. Just suicide LV, I guess, sounds cooler.
It does. It does sound very cool. Okay. Ross, do you want to tackle the next question?
Yeah, well, maybe I'll pass this
Or
even
maybe
on
ask it.
to Eduardo here and just say, well, how do we actually distinguish between an intraventricular or intracavitary gradient from mitral regurg? And actually, maybe I'll add another one. How do we distinguish between LVOT obstruction and also aortic stenosis? Because that would be another one that would potentially come up. How do you approach this, Eduardo?
So first of all, I'll start by saying I don't feel particularly experienced enough to really be able to, completely say for 100% certain that I'm being able to distinguish these two. I mean, usually in theory, and if their patient's stable and non-tachycardic, you can look at the shape of the gradient, right? So the shape of the gradient would be just your dagger shape. This is your classic textbook dagger shaped a gradient, which usually points to LVOT obstruction. But in reality, your patient's going to be very tachycardic, very sick, your very hyperdynamic circulation and really trying to focus your continuous wave Doppler line and trying to avoid the mitral valve and focus only on the LVOT. Sometimes it's hard. Sometimes I just see a really large gradient and I'll just measure and it's 4 or 5 meters per second. And that's usually the velocity that you would expect either with a severe LVOT obstruction or with mitral regurgitation. So for me, it's really hard. And what I try to do is just if the patient has a baseline echo and it is really recent, then that's really helpful. Patient did not have aortic stenosis before, and patient did not have mitral regurgitation before. And so if this is a new MR, I can start to think maybe this MR is caused by systolic anterior motion of the mitral valve, and that's SAM, which is the same pathophysiology as your dynamic LVOT obstruction. And so I would just use my clinical judgment and say maybe this new MR in the context of this patient with a very tachycardic, very escalating doses of norepinephrine, low pulse pressure, and a very high gradient that might or might not be obstruction, but might be a new MR, but might be the same underlying physiology. This LV is too empty to function. So I would just switch into treatment mode, which is how can I increase this LV cavity size? And I don't know if that's how you approach it, Katie, or if you have some more tricks to really kind of pinpoint whether this is MR or LVOT obstruction. How do you go looking at the gradient itself? Do you increase your sweeping speed, or do you do some Jedi master tricks to kind of figure this out? I'd like to know your how do you handle this?
No Jedi tricks. And maybe just to back up for everyone, just so it's really clear what we're talking about here, like the question is that because the outflow going down the LVOT at very high speeds, right? That would be like a blue outflow going down in an apical 5-chamber view. Sometimes what you might actually be catching is this big blue MR jet that we're seeing here illustrated in the picture. And so you want to make sure you're catching the right jet. You're catching the outflow jet and not the MR jet, or as Ross had mentioned, like the aortic stenosis jet. So with MR, like I think all the things you mentioned are totally appropriate, right? Like I think you want to look obviously with color, see like, do they have very significant MR, recognizing that MR can be just from the SAM. You'll look at their old echoes. This is where sometimes like, going back with 2D and sometimes with M mode into your parietal lung and seeing if I can actually find SAM, sometimes that's useful because that makes me think like, oh, this MR is all just from SAM. Making sure that I have as good a view as possible, that my pulse wave Doppler gate is appropriately placed in the LVOT in a 5-chamber rather than catching the MR in a 4-chamber. Sometimes I'll check in an apical 3-chamber view as well, just to check in another view, right? Because you can do your LVOT like VTI and your gradients from that view as well. And that might give you a slightly different view. And then to answer the question about the aortic stenosis, right? I think this is another one. So again, if we are looking at pulse wave Doppler and you put your pulse wave Doppler in the left ventricular outflow tract, you shouldn't be catching anything post-valve, right? So there you just want to make sure that your pulse wave gate is appropriately positioned in the LVOT before the valve on the ventricular side of the valve to make sure you're not catching any post-valve gradients. Once you use your continuous wave Doppler to measure your gradient, then of course you will be catching some post-valve velocities. So there I say, like, I don't know if I've ever seen aortic stenosis and dynamic LVOT obstruction coexisting. It would be very bad luck because it would be hard to tease out which is which. But I would look with 2D, on all my regular views and see, does this aortic valve look like it's opening reasonably? And if so, I'm going to be confident that this isn't aortic stenosis, that this is actually LVOT pathology. Anything to add there, Ross?
Yeah, I mean, I think of it the same way. I think the only other thing is classically the aortic stenosis has a very parabolic, round, smooth shape to the envelope versus LVOT obstruction has that dagger shape. And we'll see a few examples of really nice dagger shapes moving on. They just are very, very sharp and pointy. They're not smooth and parabolic. So if you see smooth and parabolic, I'd think potentially more aortic stenosis. But if the velocities are approaching that of dynamic LVOT obstruction, it's probably pretty significant aortic stenosis, and you should be able to see something on 2D echo, as Katie says. It's very rare to have severe aortic stenosis, if not impossible to have severe aortic stenosis with a totally normal appearing valve. You can see it, and so I'd be looking carefully for that.
That's key. Yeah.
Absolutely. Okay, we'll move on to our next question. I'm going to throw this to Ross because I know he loves speaking about this. So what do we do about the patient who is perpetually fluid responsive? And does hypovolemia actually really exist in most of our hospitalized patients? Or is this all just low mean systemic filling pressures and some diastolic dysfunction? So there's a lot to unpack here, a lot of physiology. So why don't you take a stab at this, Ross?
Yeah, absolutely. And so this is one of my favorite things. There is hypovolemia in hospital. Like you have a bleeding patient that needs blood, they are hypovolemic. There are septic patients that come into the emergency department who have had GI losses for days and days and days that are hypovolemic. Absolutely. When you see those patients, their hypovolemia needs to be resuscitated to improve their perfusion, and they get better when they get fluids. When we see patients in the intensive care unit on the ward after several days, they're getting IV medications, they're eating sometimes they're not eating, but are they getting feeds? It's actually much more rare that these patients are truly hypovolemic, but they can behave hypovolemic. And the reason why is hypovolemia reduces the filling pressure, or the mean systemic filling pressure, if we will. But it's not the only thing that reduces it. The two determinants of mean systemic filling pressure are the volume in kind of the venous vasculature, but also the tone of the venous vasculature as well. So in sepsis, we often think about vasodilation, and we think about arterial vasodilation and vasoplegia. But there's also venous vasodilation as well. And the tone on the venous side drops. Now, for any of us right now, if we had a bit of vasodilation, we would still be able to fill because we have, fingers crossed, hopefully very compliant and normal hearts with normal diastolic dysfunction. But as soon as you start developing diastolic dysfunction, you require higher pressures to fill. Now, for a patient with sepsis who has vasodilation and venodilation, they cannot mount that higher pressure to fill unless they're getting pumped in fluids into them. So you give them fluids, they're fluid responsive, they increase their cardiac output, their perfusion gets better. But we know that these fluids will leak into the interstitium after an hour. And so 30 minutes later, an hour later after the fluid bolus goes in, they're now in the state where they have low mean systemic filling pressure, not because they're actually hypovolemic, but because their mean systemic filling pressure is low from lack of vascular tone. And so the treatment for these patients is actually not to just keep giving fluids and fluids and fluids, because that's really just a Band-Aid. It'll work for 30 minutes. But now in 24 hours, 48 hours, 72 hours, you've given them like 15 or 20 liters of fluid. And we've all seen those patients that, and oh, they were just really, really dry. Well, they probably weren't really, really dry. They probably just had a combination of venodilation with some degree of diastolic dysfunction. And the only way they could fill was when they got fluids. But instead, you could also just add some vasopressors. And those are patients that I would advocate for early vasopressors on to recruit some of that venous capacitance. And what that means is that right now, all of us right now, 70% of our blood is sitting in this kind of like pooling low capacitance veins that aren't really participating in the active circulation. But as soon as you give somebody vasopressors, you can actually increase the tone and recruit that unstressed volume into your stressed volume to improve your cardiac output. And so I think this is just such a caution, because these patients that have this diastolic dysfunction, that have this relative hypovolemia, that have this vasoplegia, often also develop intracavitary gradients and dynamic LVOT obstruction. And so I've seen cases where this persistent hypovolemia is actually just dynamic LVOT obstruction. And the treatment for this is maybe a bit of fluids while you're temporizing it, but is vasopressors and kind of addressing the vasoplegia component. Does anyone else have any thoughts or think of this differently at all?
I think that's a great summary. I mean, this is one of my greatest cases I think I've published in Twitter. This and just exemplifies what you just said, Ross, beautifully, because this was an old lady with diabetic ketoacidosis precipitated by diverticulitis and like severe diverticulitis. And the patient was admitted and was doing like she was crashing actually. The BP was really low, perfusion was terrible, lactate was rising. I was consulted to do point of care ultrasound. I saw a very hyperdynamic heart with a very severe gradient. And we were trying to decide whether this was actually caused by sepsis or something else. And then as I was scanning the patient, just a lot of blood came out the GI tract. I was actually witnessed the GI bleeding. It was a massive bleed that later turned out to be from the diverticulitis, and it was also a diverticulum that was bleeding. And so we said, "Eureka!" Right? We got the cause. This is the bleeding type of gradient, and it needs aggressive resuscitation. And so what we did, we just gave some fluid bolus to temporize the situation. We gave a lot of blood. and we turned off norepinephrine because that's what you should do. You should switch off norepinephrine whenever you see a gradient, or you should try to, because norepinephrine increases heart rate and inotropism and will, empty the LV cavity. So I needed to fill this up. I gave a lot of blood, I gave a lot of fluid, and the gradient went away. The patient was doing perfect. And I said, thank you, everyone. I saved this patient. This was because of bleeding. The gradient's off. Now I can go and have some dinner. And as I was heading for dinner, they called me and said, well, the patient is now again in the same state of shock, doing terrible, very hypoperfused. And now all the fluids you have given it for resuscitation are actually causing a lot of beeline pattern in the lung ultrasound. And I went, the patient did not have a beeline pattern before. I checked again, and that was completely true. I just created pulmonary edema, and I didn't do anything. I just temporized the situations for 1 hour or maybe 1 hour and a half. And then the patient was doing terrible again, was very hyperperfused, low pulse pressure, and actually bleeding had stopped. Hemoglobin was normal. But at this point, I decided, well, maybe I can keep on resuscitating. I should tried it a couple of times. This just kept on happening. Patients persistently volume responsive. It's no longer tolerant. What I mean by tolerant is I keep giving fluid, the patient responds, improves hemodynamically a little bit, but all this fluid ends up in the wrong place. And this ended up in the lungs. And so the gradient kept coming back. So what I mean by that is I kept scanning, and with fluids, the gradient went from 4 meters per second to less than 1 meter per second. So fluids actually improved the gradient, but it came back after a couple of minutes or hours, maybe an hour and a half. And so what I did was, okay, this is sepsis. Okay, this patient needs a pressor, but norepinephrine is not the choice, because norepinephrine it's actually worsening the gradient. I see it. And so let's stop giving fluids. It's not a permanent solution. And let's not give norepinephrine. So what are our options? And really our options is vasopressin or phenylephrine or another vasopressor that will not cause tachycardia and will not cause high inotropism. My choice, my personal choice, is vasopressin, and I give really high doses. I know some pharmacists won't let you go beyond 0.06 units per minute of vasopressin. I go to 0.1. I have even gone to 0.2, which is a very bazooka dose vasopressin, and people are scared of intestinal ischemia and other myths that we can talk about, myths of vasopressin and other HCP rounds. But in my case, I really needed some pressors to stop the LV from emptying out and having this gradient. And so I switched to vasopressin high dose, 0.1 units per minute, and it worked beautifully. The pulse pressure, instead of decreasing with vasopressin, increased. So that means cardiac output increased. The gradient went away. The skin just started becoming pink again. It was really blue and mottled, and the lactate went down. Urine output increased, and we kept the vasopressin for a couple of days. Patient had a remarkable improvement in clinical condition. So sometimes you just gotta think, what's going on? Is this really persistent hypovolemia? Is this a capillary leak syndrome? Well, I've seen intensivists evoke this explanation. The patient will need persistent fluid administration. Well, I don't think so. Maybe this was just LVOT obstruction and needed a different vasopressor.
Right. Yeah. Amazing case. And maybe I'll just hop in for a second, because that reminds me of we did a case or a retrospective observational study of TEE during massive trauma resuscitation in the emergency department. And we actually found 3 cases of dynamic LVOT obstruction during the acute resuscitation of trauma, like in the trauma bay or immediately after in the ICU. And these were patients that were getting massive transfusion, but many of them had actually had their hemostatic procedure, IR for embolization of their pelvis or OR for laparotomy. And the clinicians, from reading the notes, this was retrospective, everyone was just assuming it was bleeding, bleeding, bleeding until the TE was done, which showed, oh gosh, no, this is not bleeding. And so some of them ended up on beta blockade in the trauma bay in the midst of a trauma resuscitation, which, without kind of this understanding of physiology, and at our institution, we have access to TEE in the trauma bay. So we're starting to see this kind of physiology that I don't think has really been described in that population.
That's amazing. I love it.
Katie, some of them were your TEs when you were a focus fellow. So that was great.
That's awesome.
So maybe I'll ask a question to you, Katie. Is color so we're talking about advanced pulse wave Doppler, continuous wave Doppler. It's getting pretty complicated. And one of the things on HCP rounds that we're really kind of interested in is how do we take these learnings and apply them to people that work around the world and aren't just working where they have an ultrasound fellowship. So if we take a bit of a reductionistic approach to this, can we just use color Doppler to screen for dynamic LVOT obstruction and not do pulse wave and continuous wave? Because I think that would be helpful for many people.
That would be so helpful, and I wish it was true, but I don't think it is. I don't think I can say in good faith that it is. Color Doppler can be useful, and it's usually the first thing you're doing as you're going through your scan anyways. Really high alias flow in the LVOT should clue you in that maybe something's going on there, but you can't stop there because you really can't make the diagnosis that way, just like you can't really diagnose, severe aortic stenosis without spectral Doppler. It's the same thing. Maybe if you have a really great image and you're very confident, and with color you see no alias flow and you only see kind of that blue outflow, maybe you can say this is not as likely, but I don't think this is the case. So I think this is something where if this isn't in your skill set, but you're worried about this and you see alias flow in the LVOT, maybe this is something where you go grab someone, whether that's, a cardiologist, the echocardiography, whoever who can help you with this. Because I think unfortunately this isn't good enough.
Yeah. Totally agree.
All right. Moving on. So we've already talked a little bit about management. We're going to expand on this a little bit now. Both Eduardo and Ross have touched on this. So, we've talked about choice of pressors. Do we like norepinephrine? Do we like vaso, phenyl, other things? And who actually gets put on IV beta blockers? Ross, do you want to start talking here first, and then Eduardo can expand?
Yeah. And to start, this is a clip of a TEE clip, which is why it's flipped around. But you can see that at the top of the screen is the left atrium and then the mitral valve there. And you can see next to the septum that part of the mitral valve is just almost stuck to the septum. And so this was a case of profound LVOT obstruction with almost arresting this patient. And we placed the TEE probe down thinking that this was a massive PE, as I was about to push TPA in a patient, and we put this down and then and I think I was on like 150 mics of epi as this patient was like arresting in front of me, and it very quickly led to a 180, and the patient was fine about 45 minutes later after we stopped the epi and did it. So how do we treat this patient kind of with this TEE? So I think it helps to go back to the physiology of LVOT obstruction. So the contributors are relative hypovolemia, vasoplegia, diastolic dysfunction, and tachycardia. And so we kind of want to address these. So realistically, how it happens in most of the patients, you figure out the patient has dynamic LVOT obstruction. If it's severe, you're trying to temporize it. And the best temporizing for most cases is probably giving fluids. So we started hammering in fluids in this patient. The next thing is to address the vasopressors. And so this patient was on high doses of norepi and epi. And so often what I'll do is I'll give a push of phenylephrine or push dose vasopressin and then switch them onto phenylephrine and vasopressin to kind of get that going. And I would say that in 8 cases out of 10, or maybe even 9 out of 10, that's enough. When you recheck the gradient has improved dramatically, the hemodynamics have improved dramatically, and the cap refill has improved. So rarely do you actually have to reach for IV beta blockade. But there are some patients that need that. And so what I look for is patients that still have gradients often above 50 as their max gradient, but definitely above 30. 50 is getting quite severe. They have perhaps 2D evidence of SAM, and they're still hypoperfused on requiring a fair amount of inotropy. Not inotropy, vasopressors, or they're persistently needing fluids to fill. And so maybe they're good, but as soon as that fluid bolus that's going in wears off, their pressure drops. Those are patients I reach for beta blockers. And typically I'll use esmolol. We have access to IV esmolol, which is an ultra short acting beta blocker. And the advantage to esmolol is you can start it at a fairly moderate dose and within 5 minutes really see the effect. And if you've chosen wrong and their tachycardia is actually compensatory, you can quickly stop it. And so how I think about whether or not the tachycardia is compensatory, I think in medical school, certainly I was taught very much that tachycardia is sinus tachycardia is a compensatory mechanism for shock. I don't think that's actually as true as what we might say. For a young trauma patient, tachycardia who's bleeding to death, tachycardia is very much compensatory. But for that patient with septic shock, a lot of the tachycardia is driven by adrenergy, driven by the catecholamine storm, the SIRS, and all of that. So many patients, particularly with sepsis, actually are not compensatory tachycardia. And the tachycardia is actually implicated in some of their shock, particularly if they have intracavitary gradients and LVOT obstruction. And so for the patients with sepsis, I'm more inclined to use IV beta blockade. There's increasing evidence potentially that this is actually beneficial for patients with septic shock, although there's some questions about which populations this should be applied to. And I often find that when you slow their heart rate from, say, 130 down to 100 or 90, kind of a moderate reduction in the tachycardia, you see improved cap refill time, improved modeling, and they have better hemodynamics with a slightly lower heart rate. But if their pressure started tanking while I was doing that, then I would probably back off it and say maybe this tachycardia is a little bit more compensatory.
That's actually great, Ross. And I would just add, I mean, of course, even sinus tachycardia may not be compensatory, but then other heart rhythms, then that would increase your chances of this non-being compensatory. So especially rapid rate AFib, which should be thought of as sinus tachycardia. What if the rate is 160 and you have a high gradient? Then I will be very inclined to slow down this AFib, which might actually be contributing to the obstruction physiology. I don't know if you agree with that. And then the other important aspect would be deciding whether this tachycardia is compensatory or is actually counterproductive and leading to obstruction. I think that the type of gradient will change my interpretation of this question. So if I'd see, and maybe you don't agree with me, this is not scripted. if there's a mid-cavitary gradient and there's a tachycardia of 120, I might be less convinced that this tachycardia of 120 is creating this mid-cavitary gradient, and it's creating all sort of problems. And then maybe if I slow down, I would think I would take down this compensatory mechanism, the patient might crash. And compare that to a patient with a tachycardia of 160, and the gradient is not mid-cavitary, but actually LVOT obstruction gradient, where slowing down the heart rate might open up the LVOT tract. And then I might be more inclined to give beta blockers to this patient. I don't know if you guys agree with me, but the type of gradient and maybe the rhythm or the underlying rhythm leading to tachycardia might also be things to consider whether giving beta blockers.
Yeah, no, I totally agree. And I think that, it's partly why ultrasound is so useful here, because these are things that would be scary to do if you didn't have the image in front of you saying yes, this is the physiology that's going on, right? Because a lot of this is counter to what we would otherwise do. The worsening shock patient, you're going to certainly you're going to take away their inotropy, their epi, their DOB, even the inotropy that's present in norepinephrine, you're going to take all that away. You're going to maybe beta block them, right? This is somewhat counterintuitive. So this is why this is such a powerful diagnosis, because you have this image and it can give you the confidence to say this is what this patient needs. And it's so satisfying when you see this, right? Because these people turn around so quickly, often within a matter of minutes to hours. So I totally agree with what's been said.
Yeah, I think that's a great segue actually into the discussion. Maybe why don't we go to question 7 first? And
yeah, sure. Let's do it.
Yeah, so the question kind of related to what Eduardo asked here. So we're talking about intracavitary gradients, but there's differences in where the gradient occurs. It could happen in the mid-cavitary area, or it could happen at the LVOT. And so maybe Katie, to take us off, how do you think about the significance of gradients that happen mid-cavitary versus at the LVOT? Does it impact your treatment? How do we actually figure out where the gradient is?
Yeah, so Eduardo kind of touched on this, right? So a mid-cavitary gradient is when you have the obstruction just due to the ventricular walls kissing in the mid-LV. There's no associated SAM, so there's no actual outflow tract obstruction. So kind of as Eduardo touched on, this is the farther away from the LVOT it occurs, the less concerning to a degree it is, right? Because you're always going to have some degree of gradient across the LVOT. That's normal, especially right at the apex. So often, the mid-cavitary gradients you're going to be a bit less worried about. You may not reach for the big guns like beta blockade. You may, start with a little bit of fluid, maybe titrate their pressors a little bit. I think we talked a little bit about how you can identify the location of the gradient, and Ross has put a few nice slides in here, right? So this would be, you can either walk your PW back from the LVOT to the apex, or you can start at the apex and walk your PW forward, either way. So here you can see our pulse wave tracing is right at the apex. And we can see that we have this classic, very dagger-shaped LVOT obstruction here. So this would be a mid-cavitary gradient, right? It's not close to the LVOT. Here we're walking, but it's probably still traceable here. As we move our pulse wave Doppler forward, you can see that this becomes less and less interpretable. And as we're all the way at the LVOT here this flow is totally uninterpretable. So this is probably going to be a mid-cavitary gradient occurring somewhere along that spectrum, rather than right at the LVOT. Ross, do you want to add to that? Because these are your pictures.
No, I think that's perfect. So I am less concerned the closer the gradient is to the apex of the heart, and I'm more concerned the closer it is to the actual left ventricular outflow tract, because there's a greater volume of blood that's being obstructed. And in fact, as Katie mentioned, if you go to the apex of the heart, like within a couple millimeters of the wall of the apex of the heart, there's actually always a gradient there, because the walls are so close to each other that there's the blood that gets ejects at a very, very high velocity. And then that slows down as you get into the wider part of the cavity. And then there's a bit of an acceleration as it starts going out the LVOT. Yeah, that's great. I thought this would be a good one just to hop to. So that makes sense.
Perfect.
I don't actually do this. I should. I'm just learning right now. In trying to find exactly where the point of gradient of the gradient is coming from, and I see you place the PW in the apex, and then maybe mid-cavitary, and go to the left ventricular outflow tract, and I see all dagger shaped in these images. What are you actually looking for? Are you looking for the point of maximal velocity, or what exactly would be the place where you say, oh, here, this is the exact location of this gradient?
Yeah. So I don't think it really matters. Maybe that's the first thing, that if you're not doing it, I don't think you're really missing out on much. Like having the continuous wave Doppler to give you the peak gradient is by far the most important. I think this is somewhat academic. It's kind of like a bit of a party trick. Everyone likes doing it. So I don't know. That's probably the main reason that we do it. And so what I'm looking for is I set the pulse wave scale to the maximum velocity. But for anyone who's not as familiar with Doppler, the pulse wave, the maximum velocity that you can resolve is going to be less than continuous wave, because just due to some of the intrinsic ultrasound physics. And so even when you set the maximum velocity on your pulse wave, you probably can't resolve any even remotely significant LVOT obstruction. So I start at the apex, and as I start moving down, you start seeing the aliasing of the LVOT tracing get more and more and more. And so you're actually looking to see how much aliasing there is, how much wraparound there is almost from the LVOT. It's not a precise science. I find that it's not really that useful either, but that's how I do it.
So the more wraparound you have, that will be the place where you say, here is the peak gradient of this heart.
Wherever you decide, you can say, because nobody can ever tell you otherwise.
Yeah,
so
and I usually start at the LVOT where it's like where it's very aliased, and I usually walk backwards and I look for the spot where now I can trace something.
Oh, fine. Okay, that makes sense. And then, of course, if you see the mitral valve kind of moving in systole with anterior motion and obstructing the LVOT,
then you know you're in the LVOT, not mid-cavitary for sure.
Maybe not.
Sure.
Okay. Well, we'll go back to our previous question, because I'm so curious about this one, because it's kind of a bit of an about face from some of the things we've just been talking about. What happens? So occasionally we can actually get dynamic LV obstruction caused by RV failure in cor pulmonale. So it's the fact that the RV is so big, you're getting this septal flattening that's causing the LV to be so small, to have such poor filling, and to have such a narrow LVOT. So what do we do there? Do we manage it the way we've just talked about, Ross, or do we do something different?
Ooh, this is tough. I've only seen maybe a handful of cases of this. It's not common, and it's super, super hard to treat. And it's honestly a little bit scary to treat. So the problem is that you have two almost competing causes of shock. And you have to be pretty sure that one of them is the predominant cause. And so the two causes of shock are RV failure with a dilated dysfunctional RV that requires inotropy, pulmonary vasodilators, ultrafiltration, and supporting the MAP using vasopressors. But on the other hand, you have some degree of LVOT obstruction or intracavitary gradient that requires potentially more filling. I say more filling and not fluids because in this case, the treatment is certainly not fluids, but needs afterload and then also needs a reduction in inotropy. And how I think of it, in these situations, I want to make sure that the dynamic LVOT obstruction or intracavitary gradient is actually significant. So I want to make sure that it's above 30 and probably above 50 if I'm going to really start trying to think about the LVOT side and not just focus on the RV failure. If it is significant, the cause of LVOT obstruction in this patient is probably that there's not enough blood making it from the right side to the left. And so the treatment for this is actually not to give fluids. The treatment is really to support the RV. So my treatment for these patients consists of pulmonary vasodilators, aggressive ultrafiltration on dialysis with close monitoring to make sure that you're not going too far and taking too much volume off, and then supporting with vasopressors, particularly vasopressin that doesn't have any adrenergic effect, so won't contribute to inotropy. Now, for RV failure, often we use inotropes like milrinone or dobutamine. I would avoid those in this population if I think that the intracavitary gradient is actually significant. Because although, yes, you improve your RV inotropy, that effect on the LV could actually worsen the LVOT obstruction. And what I'd want to see is that over time, the LV diameter and diastolic kind of diameter isn't getting bigger and bigger, the gradient's coming down, and any 2D evidence of SAM or LVOT obstruction is improving. Yeah. What about you guys? This is something that every time it happens is always like a little bit of a nightmare and requires a lot of thinking.
Yeah. I think this is an example of how we shouldn't just treat labels. Like if somebody gets labeled as dynamic left ventricular outflow tract obstruction, and then people want to see an algorithm as what should you do in this situation. And instead of going for your algorithm and looking for a table that can give you the answer, you should go back to the basics and remember what's causing LVOT obstruction is an empty LV. So now your focus should be not to look for an algorithm how to treat LVOT obstruction, but to think physiologically how to increase LV cavity size. And then, in my opinion, LV cavity size in this situation is really compressed by two things. The first one is low blood flow to the LV because of increased pulmonary vascular resistance. And the second is a blown up RV compressing the LV walls. And so the first one, and me as a nephrologist, I like to tackle. The first one is hard for me to tackle, which is a high pulmonary vascular resistance. So I'll talk to my pulmonary fellows and like you, maybe try to vasodilate the lungs with inhaled vasodilators, maybe not use inotropes. And then the second one I like to treat, because the second one, treating a very dilated and blown RV to decrease its size and maybe increase LV filling, it's something I can do with ultrafiltration or diuretics. And then how do I titrate these drugs? How do I know I'm not taking out too much volume so that now I will worsen the obstruction of the LV? Well, this is a personal opinion, but Vexus has really helped me. So if I see a very pulsatile portal vein, and what I mean by, people think greater than 50% is a severe portal vein pulsatility fraction. I would say in my world, 50%, I don't care. It's not that bad.
Not that bad.
So for 120, 140, 200, 250 percent pulsatility, those are the portal vein pulsatility that I'm really saying, okay, this patient needs to be on diuretics or having volume removed. And when you see 120, 200% pulsatility, you gotta really think all the blood flow that's coming into the right atrium is going back. So there's really no harm on taking it off. And we've had really good results of treating very high, very severe portal vein pulsatility fractions and aiming for a pulsatility of around 40 to 50%. That would be reasonable. And you see 50%, that would not be severe. It would be kind of my goal to just get there. And then that usually correlates with a decreased RV size and an increased LV volume, and it probably would improve this disease. I don't know have you used portal vein pulsatility in your in your cases that are similar to these? I mean, we certainly use it in severe tricuspid regurgitation, but also in just this severe pulmonary hypertension with acute core pulmonare, which it's more likely the patient will respond to diuretics the more severe the alteration is. That's just it. It's not rocket science. So I'm very wary of treating a portal vein pulsatility of 30-40%. I'd say maybe that's normal for this. Look at this RV. Wouldn't you expect to have with that portal vein pulsatility? But maybe 240, 300% pulsatility. I mean, that's just too much.
Yeah, I agree. And I think all three of us could probably talk about Vexus for another hour, but maybe in interest of time, we'll go to our last question.
I was about to say we almost finished the whole HCP rounds without talking about Vexus. I was going to be proud of us, but Eduardo, you ruined the streak.
I'm not going to let that.
We did that one already. Oh, sorry. Right. Here we go. Last question.
So, yeah, maybe I'll just ask you this, Katie. So I see these patients in the ICU. They have bad LVOT obstruction. I get to put them on IV beta blockers. It blows everyone's mind as their hemodynamics get better with beta blockers and shock. It's great. And then I just send them up to the ward and never see them again or talk to them. So what happens actually when the patient leaves the ICU and they've had a dynamic LVOT obstruction? How do you further triage, risk stratify, and manage these patients when they're on the ward and beyond as a general internist who sees them afterwards?
This is a really good question, Ross, and I think something that's kind of under-recognized. So the first thing is that, like, I think this should go in their documentation. So please, like, when you're sending these people home, this should be in their discharge summary that, like, while in ICU, they develop this physiology so that if the patient comes in sick again, everyone is made aware that this can happen in the right physiologic milieu. What I usually do on the ward, I will usually repeat. So they've probably had an echo in the ICU demonstrating this physiology. If it hasn't yet been repeated now that they are well and their predisposing conditions have been ameliorated, I will typically either repeat this myself, and if I'm very reassured, I may just order an outpatient echo for them, or I'll get an inpatient echo to see if they still have any degree of gradient left. If they have nothing, either with rest or with Valsalva, and I'll put that in my indication if I'm ordering an echo, previous dynamic LVOT gradient, please reassess. If they have nothing, then they're probably okay. And, just with this label as a future flag. If there's still a degree of gradient at rest, but even with exercise, then I will send these people to cardiology. I usually see them do outpatient echoes, somewhat serially. The people who have even a degree of gradient at rest sometimes also get put on beta blockade long-term. And then again, this is just something to be aware of for future, especially the people who may have ongoing predisposing conditions. So the cirrhotics or people like that.
Brilliant. Well, thank you guys so much for hopping on here, just mindful of the time. And thanks for everyone for tuning in. We'll pop this on YouTube in a little bit.
Yeah.
Thank you. Thank you guys so much for having me. This was a really great discussion. I'm really thrilled to have been here.
Thank you, Katie. This has been amazing. Check out our webpage, hcprounds.com, where this will come up. And then you can see our previous episodes and then the future episodes as well. Thank you for tuning in.
Okay.
Awesome.
Thanks, guys.
Take care, everyone.
Bye.
Bye.